These are the principles we follow. And this is one way of doing electrodiagnosis. There are other ways to do it, but this is not a bad way. Believe me, this works really well. First of all, when you do neuroconduction or EMG, you do this to make diagnosis, right? And it is therefore a part of a neurological examination. We consider neuroconduction study and EMG an extension of neurological study, right? So we think it is most important to take a good history and good physical exam. And that's how I train. I'm a neurologist by trade, although I do mostly electrophysiology. My mentor in Iowa, a very well-known guy, SARS, was principal Osler. Osler is a very famous neurologist who taught neurology in Johns Hopkins, and SARS must have studied there. But Osler is famous for saying that history is everything. That's how neurologists learn. You got to remember that history is everything. And then he said, listen to the patient who is trying to tell you the diagnosis. And that is really true. You really have to spend a lot of time with the patient who is or she is trying to tell you what's wrong with it. And you cannot ignore. So that's very important that you do this first before you do neuroconduction study or EMG, which is just an extension of history of physics. Right? But today we are doing electrodiagnosis, so I just brought one slide for history and physical. Now, do these people have a handout?
Yeah, I will send it the handouts.
I'm sorry?
I will send all the handouts through emails.
Already or going to? This afternoon?
Yeah.
But they will have it, right?
Yeah.
So they will have, so you will all have the copy of this slide, so you don't have to write it down. Right? Is that correct? Yeah, okay. So I wrote one slide for history and physical, right? And that is the question. When you do neuroconduction study, you mostly do it for neuropathy. Right? And there are many ways to classify neuropathy. Yes? At least three good ways. One, which I didn't bring slide, one is to divide it into three: acute, subacute, and chronic. Right? This is really very fundamental, right? Acute neuropathy like Guillain-Barré syndrome. Right? Subacute like CIDP, chronic inflammatory demyelinative neuropathy, and chronic like CFD, the hereditary CFD. So that's one way to classify, which is very important. Second way to classify is depending on the site of the involvement of the nerve. Is the cell body affected to begin with? Is this myelin which is affected? Or is this axon itself? And so we talk about neuronopathy, meaning cell body to begin with. And if the cell body is affected, and of course axon will be affected secondary. So this is neuronopathy. If the axon is affected to begin with, we talk about axonopathy, right? And if myelin is affected to begin with, we talk about Schwannopathy. Schwann cell produce myelin. Schwannopathy or myelinopathy, the same. Right? So this is also important, right? Depending on what structure of the axon affected. Neuronopathy, axonopathy, and Schwannopathy or myelinopathy. Right? But that's not what we're talking about here. This third classification is important for electrodiagnosis. And that's why I brought the slides. And that divide neuropathy, again, these things for some reason always come in 3, right? Never seen a classification that comes in 4. I have to make it one sometime. And this one divides into mononeuropathy, polyneuropathy, and mononeuropathy multiplex. And let me go over this very quickly because this is very important, right? And simple. And you gotta remember, right? Mononeuropathy, as it says, meaning just one nerve is affected. Carpal tunnel syndrome, if it's a median nerve, it's usually carpal tunnel syndrome, right? Very common. In Iowa, I would say 40% of patients we see. We see a lot of patients, but 40% of them probably carpal tunnel, right? So very, very common, and you need to know how to assess this. But one nerve only, that's mononeuropathy. Okay. Mononeuropathy multiplex, which I think I'll talk tomorrow in conjunction with motor neuron disease, which is better, right? But mononeuropathy multiplex is a little different. It's one nerve, but many of them. Yes? And that is similar in a way to polyneuropathy. Let's begin with polyneuropathy first. In contrast to mononeuropathy, one nerve only, polyneuropathy, of course, affects all the nerves, right? That's what it means. But when you say polyneuropathy in English, it actually implies many nerves, but it implies two more things. One, it is more or less symmetrical. And two, it is length dependent, meaning the longer the nerve, more affected. Yeah? That's like a diabetic polyneuropathy. Diabetes is so common. Everybody in Iowa is obese, and everybody seems to have diabetes. and so diabetic neuropathy for us is about 30 to 40% of our patients. But they are more or less symmetrical and length dependent, meaning the legs are more affected. So if you see a patient, and if patients come and say, Dr. Kimura, I have my fingers tingle. If that's the first thing patients say, then your question always has to be, how about your toes? And if patient says, no, nothing wrong with my toes, that's not polyneuropathy, right? That's either carpal tunnel syndrome, myelopathy, many different possibilities, but not polyneuropathy. So polyneuropathy almost always affects the leg first, right? And so that's polyneuropathy, many different kinds. Systemic disease, autoimmune, very common, yeah? Guillain-Barré, CIDP, metabolic, toxic, like medication, vincristine. If you take vincristine for cancer, for example, then you always develop, in this case, sensory neuronopathy. Sensory ganglion is initially affected, right? So metabolic and hereditary, very common. The most common polyneuropathy that we miss in diagnosis clinically is hereditary neuropathy. Because in America, I don't know how it is here, in America it's a little difficult to get a good family history because many patients are adopted and they know nothing about their own family. And without family history, it's hard to make hereditary neuropathy. So this is probably what we miss most. But that's polyneuropathy, right? Now, mononeuropathy multiplex, one nerve at a time, but many of them. So eventually, if you look at the patient with mononeuropathy multiplex, you think patient has polyneuropathy, yeah? Because all the nerves are affected. But if you take a good history, it's different. He'll tell you, right leg, 6 years ago, 2 years later, left arm. This kind of story. That's why you have to take a good history. Then you know right away, again, this is not a polyneuropathy, it is mononeuropathy multiplex. There are two kinds. When I was a resident, that's a long time ago, if my staff says mononeuropathy multiplex, they almost always meant polyarteritis nodosa, which is a fasciitis. Yes, because that was only mononeuropathy multiplex we knew then. But now we know that the demyelinative mononeuropathy multiplex, which is actually more important because multifocal motor neuropathy, which is the demyelinative mononeuropathy multiplex, mimic motor neuron disease, right? And the motor neuron disease is such a bad diagnosis. You really have to be very careful before you establish a diagnosis. You always must exclude demyelinative multifocal motor neuropathy, which I'll talk about tomorrow, right?
There's something they call hernia-associated polyneuropathy, under which title we can call it
Metabolic. Yes, certainly true. Okay, so that is history and physical, right? So the number one principle, history and physical, which I want you to remember. Always ask your patients what's wrong, always examine, right? Now the reason, if I go, the reason this classification is important is that mononeuropathy and mononeuropathy multiplex lesion site is very focal. Interrupted carpal tunnel syndrome at the wrist, actually in the palm, but it affects the nerve only within 1 centimeter, probably 0.5 millimeter, very focal. The same here. Right? In contrast, polyneuropathy involvement is very diffuse everywhere. And therefore, we will have a very different approach, electrodiagnosis-wise. For mononeuropathy and mononeuropathy multiplex, basic approach is inching. It's a very restricted lesion, and you might as well inch. In contrast, if it is polyneuropathy, there's no point studying short segmental inching study. You might as well take a long passage, and the long passage is either FA or HFX. So, based on the history and physical, you have to decide what you're going to do. And that's why this classification is important. Okay. So the next point is this. When you stimulate a nerve, you tend to look at the oscilloscope, right? Looking for the waveform. But that's not a good idea. When you stimulate, you always look at the muscle which is twitching, right? And very few people do that. But you have to do it because that's the only way you know which nerve you're stimulating. And I'll show you later how to go about it. Especially if you we stimulate the median nerve in the palm. And I don't know how many of you do this, but this is now becoming routine in America. Because carpal tunnel syndrome is right in here in the palm. And so when you stimulate the median nerve at the wrist, that's a proximal stimulation. But we like distal stimulation better than the proximal stimulation, right? So we always stimulate here, record compound muscle action potential here, antidromic sensory here. And I'll show you this a bit later. Now, in so doing, when you stimulate around here, there are two nerves. One is a median nerve going in, recurrent branch going to the abductor pollicis brevis. But there's another nerve going in here, going around. That's the ulnar nerve, deep ulnar branch in the palm. And when you're stimulating in this area, sometimes you don't know which one you're stimulating. But if you do know, if you look at the twitch, because if you stimulate the median nerve Of course, you stimulate the activate abductor pollicis brevis, so the thumb abduct. But if you stimulate outer nerve, thumb adduct. You know what I'm telling you? So just by looking at the twitch, you know which nerve you stimulate. That's why it is important to watch. Yes? All right? And if you do the stimulation here, the median nerve, then see if you just stimulate wrist and elbow, you may not get much response in this. This is multiple myeloma. So if you finish this, you don't really know whether this is a loss of axon or conduction block, unless you stimulate more distally. And when you stimulate in the palm, if you get a good response, you know there's a conduction block. And this happens all the time, right? Not in carpal tunnel syndrome. In carpal tunnel syndrome, for reasons that I don't understand, there's very little conduction block. The delay is tremendous, but the conduction block rare, right? So for carpal tunnel syndrome, it doesn't matter, but for other polyneuropathy, it does. Okay, so the next, let's see. So this is distal and proximal. When you have a lesion site, I think basic principle is to go stimulate distal to the lesion site and proximal to the lesion site, and you compare. And if there's a conduction block, see this is distal to the lesion site, and this is proximal, and you know there's a conduction block. If this is also small like this, then you say that's an axonal degeneration. You have to stimulate distal, right? So that is the principle of distal versus proximal. And the distal stimulation actually is more important, because that will tell you whether the axon is dead or alive. So remember that. It's a stimulation distal to the site of the lesion that counts. All right? Okay, let me give you one example, and I think we can finish there. This is a 52-year-old woman who had a Lyme disease. Do you have Lyme disease here? You don't have Lyme, do you? Oh, okay, Iowa. Next to Iowa is Wisconsin. You know, Wisconsin is where Lyme is most prominent, but we are next state. So sometimes we get a patient with Lyme, which is nothing in this case. But what happened in this case, because of the Lyme, they put the PICC line in her right biceps area. You know what PICC line is? You know, it's do I know that? It's a peripherally induced central catheter. In other words, they just want to maintain the vein. Eh? So, PICC line placed in her right biceps area. In here, okay? And then something happened. This happened. Now, what is this? This patient is trying to bring the wrist up, but unable to do so, women to do so. So your diagnosis is? All right, very good. Anybody else? Okay. So this is a wrist drop, right? This is a wrist drop, but it's more than that. She is trying to raise, and you see the hand deviate radially, and this is what we call radial deviation. Now, why does the hand deviate to the radial side? I'm not asking you. Anybody? Why does, when you try, he has a wrist drop, yeah, and he's trying to raise it, and the hand deviates to the right. There are two main muscles which bring the hand up, dorsiflex. What are they? One is, this is called an extensor carpi. Very good. Extensor extensor carpi radialis, extensor carpi ulnaris. So when as he said, when you try to do it, and if it deviates to the radial side, you know extensor carpi radialis is intact, and you lost extensor carpi ulnaris. And that tells you what? How can you lose extensor carpi ulnaris and maintain extensor carpi radialis? Anybody? That's because when you have a posterior interosseous nerve, as he said, then the branch going to the extensor carpi radialis is already gone, and you get the extensor carpi ulnaris that spare the extensor carpi radialis. So if you're a good physician, you look at it, and if you say this is a radial nerve palsy, you get 50%. But if you say this is posterior interosseous nerve, you get 100%, right? All right. But how did it happen with the PIC line placed in her right biceps area? Do you know that? Do you know that?
Radial nerve, it is when
Give him a microphone. Is there a microphone? Yeah.
the pathway of the radial nerve through the arm, something underneath the triceps, and then likely oblique way, then enter of the arc of Franchi, and then bottom through, supply only the extensor carpi radialis longus and spare this, and then there is a problem. The oblique way through the triceps, underneath the triceps. So it is the radial nerve supply some fibers of the brachials also as a flexors.
Yes, the radial nerve. So this is a radial nerve, all right, and it divides into posterior interosseous nerve and the sensory fiber right here. This is a biceps tendon. A lot of people think that deviation happened in the forearm. But not so. It happened at the biceps tendon level. So if you insert the catheter here, you can injure one or the other selectively. And in this case, they must have injured the posterior interosseous nerve, sparing sensory fiber. And I think you should remember this. The posterior interosseous nerve syndrome, most common to us anyway, is after biceps tendon repair by orthopedic surgeons. They try to repair the biceps tendon and they nick which is very close, and they know it. But nonetheless, they often nick this nerve, and then the patient develops posterior interosseous nerve. And in that case, sensory nerve is intact, only motor fibers. And let's see, do I know? Extensor carpi radialis has already given the branch, and so that is spared. Yes? So this is the level where the involvement is. And that's exactly what happened. And when we did the radial sensory, which is completely intact, because it's already separated, and when we did the motor, you get a good response distally, but nothing proximally. And this is a conduction block. But in this case, when we stimulated posterior interosseous nerve distal to the site of the lesion, we get a good response. Meaning what? That's why distal stimulation is important. Well, when we get a good response, distal, the patient is paralyzed, but when we stimulate the radial nerve distal to the site of the lesion, there's a good response. Meaning, axon survived. And therefore, even though the paralysis is complete, prognosis is good or bad? Always good. See, I think that is one of the most important information you can get, that you cannot get critically. Any paralysis, In this case, brain nerve palsy, patient is unable to move. And so, referring physician already knew the patient had posterior ethmosis nerve palsy. Now, why does he then refer the patient to you? What is the reason that the patient sent to you for electrodiagnosis? Prognosis. Yes. Referring physician would like to know, is this going to be all right or not? Which you cannot tell clinically. But you can, because if you stimulate the nerve distance to the site of the lesion, and if you get a good response, you know actions are still there, right? And so weakness must be conduction block. And you say, yes, despite the weakness, this guy is okay. So that is the reason that the distal stimulation is important, right? Yeah? Oh, in Japan, we call wrist drop ghost hand. Because Japanese ghost, this is the time of ghost appearing in Japan. Japanese ghosts come like this. And in America, I'm in America, right? And they call wrist drop ghost hand. And so in America, I keep saying that this is a ghost hand, and nobody understands that. Nobody. And I was very curious, why do, in America, this is called wrist drop or Saturday night palsy. Are you familiar with that? Students go out, Saturday go out and they drink, and they usually drape the hand over the bench. And in the morning, you get up and you have a wrist drop. Or sometimes called, in America, called honeymoon palsy. Usually men, when they go honeymoon and they have their arm under the bride's head. And when she goes to sleep, it's very heavy, right? So in the morning, he gets up and he has a wrist drop. And those ghost hands, they don't. And just 2 years ago, I found out why in America, ghosts appear like this. They don't have a leg, but they have no wrist drop, right? The arms are intact. And so now I know why they don't talk about the ghost hand. But in Japan they do. Okay, next. I'm running out of time. But principle number four is a linear or non-linear. Okay? And this is another very, very important principle that we follow. See, I told you that we stimulate in the palm, right? Median nerve. So for median nerve, we stimulate the palm, wrist, elbow, and axilla. And you record from the abductor pollicis brevis. And you record this, yeah? And these motor action potential look more or less the same. But if you look at the sensory, antidromic sensory, these are three simultaneous recording. Antidromic sensory potential becomes smaller and smaller. And when you stimulate at the axilla and record here, it is very small, right? Now, but this is normal, right? Now, how do I know this is normal? The amplitude is changing so much. In fact, when you read a textbook, it often says that up to 50% reduction is normal, right? But this is really more than 50%. This is about, you lost about 1/3. 2/3 is lost. When you read 50% in the EMG text, don't believe it, right? Because authors who don't know what to say usually say 50%. So when I read 50%, I say, these guys don't know what they're talking about. But looking at this, this is normal. Why do you know that?